All right, I was going to do this another day, but I want to just get it done now, and it's relatively short. So we're going to just do this quick video on the lecture for renal disorders. It's a pretty quick run through and then a little chat about dialysis, and we're pretty much covered on what we're going to cover in terms of renal illness. Um, so let's jump right into it. Renal, we know, refers to the kidneys. I wanted to start off with just this image that does take a little bit of a closer look at the kidney than what we've done before. I'll bring up my little zoom thing here. This is, oh shoot, probably better if I turn the screen on, huh? So this is our image of the kidney. This section on the left is what we're sort of used to seeing. It's this, bean-shaped organ that sits in the retroperitoneal space. Unfiltered blood comes in here in the renal artery, goes to the renal medulla and passes through one of these nephrons and then recollects into the renal vein where it goes back to the inferior vena cava and back up to the heart to be redistributed. What I want to take a look at just briefly is this piece that we haven't talked about too much, and that's this base unit that I keep mentioning called the nephron. So, nephrons obviously don't look exactly like this in real life, but are roughly to this taste. Our nephrons are basically just, there are a couple million of these little units inside each kidney, and as blood comes in through the renal artery, it slowly split and split and split and split and split until it gets to this break right here, or this barrier, and all of our nephrons sit along this little barrier. So blood comes into the nephron through this right here. It's called the proximal arteriole. Most of the vocab here you don't need to know off the top of your head, but can be helpful. And then it comes here into this little capsule called the glomerulus. Impossible to say. This is where some of that first filtration happens. Some of that water comes out, some of those toxins come out, and then it continues out here through the distal arteriole, which comes down. And we can see that this distal arteriole is sort of linked up with this venule right here in several places. So this right here is called the loop of Henle. It's this little loop of this tube right here, leading up to the coming off of the glomerulus. Yeah, that sounds right. We have what's called the proximal convoluted tubule. That's this piece right here, which goes down into this, our loop of Henle, comes up to the distal convoluted tubule, and then it collects here into one of these ducts that eventually comes here into this section where they all collect together, which we call the renal pelvis, and then down through the ureter, and that's our urine. That's what's being formed here is our urine. So blood goes here through the capsule, comes down to this loop of Henle, and does some swish swashing. It might have some volume put back into it, might have some more volume taken out of it, might have some ions put back into it, might have some ions taken out of it. And then it comes here into the venule, and that venule comes back, and they all collect together, and they go into the renal vein, and then they go into the inferior vena cava. That's just a little bit of a closer look at this base unit of the kidney called the nephron that I keep mentioning. I think it's a good general idea to understand that blood comes in and it sort of passes along these different tubules, and ions are exchanged and fluid is removed. So that we can maintain the right amount, we can remove the waste from the body, we can maintain the right amount of electrolytes, we can maintain the right amount of fluid volume. All these things that are being done by the kidney are number one organ. First thing we're going to talk about in terms of kidney diseases is an easy one, kidney stones. Excessive waste products over time can build up here in the renal pelvis, and they can crystallize. These different, particularly our ions like calcium, can crystallize and they can form these little stones that we call renal calculi, or more commonly, we call them kidney stones. These can continue to grow over time. They start off very small, and then as more urine comes in contact with them, more things can crystallize off and they can get larger. And what can happen is that they can come down into the ureter and cause us a lot of pain. They're very, very painful. Um, Most kidney stones, we help people with pain management. We help supplement their fluids. In big cases, we might give them something like Flomax to help help them urinate more. And with a little bit of some pain management, they pass the kidney stone on their own. They urinate it out, and it's uncomfortable, but it's not too dangerous. In really severe cases, our kidney stones can completely block this ureter, and we can lose our ability altogether to pass urine down that passageway. Our treatment, in terms of the EMS sense, doesn't make a difference, but those patients could end up needing surgery, and sometimes they can get stents in their ureter, um, just like we might get stents on the heart. Sorry. Last thing about these in terms of our assessment, usually they prevent as really severe, often sharp pain in the flank. And one of the ways that we can help differentiate this from other diseases that might cause pain in the flank is if we percuss on their back. That means, just like firm tapping on their back near their kidneys and near their ureters. A lot of times we can reproduce this pain, and that is a really strong indicator that these are kidney stones, because we're smacking and we're causing that stone to jostle around a little bit, and it causes a lot of pain. All right, so coming off of kidney stones into our more severe kidney diseases, AKI and CKD. Now, these are two of the same process that we just split into two groups. Acute kidney injury is when the kidneys are not working properly, but it's the result of a right now illness of some kind, and usually we can correct it. Um, Most often it comes from just the kidneys aren't getting enough blood passed through them. Uh, that leads to a lot of other issues as well. We start to build up acidity, we start to build up nitrogen, we start to build up all these other waste products. And our kidneys don't work as well over time if we don't perfuse them well enough. Really, any kind of not enough blood or not enough juice can result in not enough blood getting passed through the kidneys. So sepsis is a big one. We see AKI in a lot of our sepsis patients, really severe dehydration, bad trauma resulting in hemorrhage, severe heart failure, all can cause these acute kidney injuries. CKD is a lot of the same process, but it's irreversible and it continues to progress over time. We most often see this associated with diabetes and chronic hypertension. Um, and when it goes on long enough, we need to treat it with dialysis. So I have a quick slide here about the different stages of CKD, and then we'll jump into dialysis. And what I want you to notice is this number that we relate all of these stages of CKD to, the GFR. The GFR stands for our glomerular filtration rate, which is an estimate of how much volume we're passing through here every minute. So we measure this in, I believe it's mLs per minute. And as we see that number go down, we know that our kidneys aren't functioning as well. And that's how we classify the different stages of CKD. When our CKD gets bad enough, or in the case of AKI, maybe we do it once or twice, we need to get dialysis. Um, all types of dialysis have the same goal, where there's two main ways that we do it, but for both of them, we want to eliminate waste. We want to normalize some of our blood chemistry, especially these strange excess ions that can build up, things like potassium and calcium and sodium and chlorine. Those ions, balance those out, make sure that we're not getting too high or too low. And then we want to remove excess fluid from the body. Remember that our kidneys process out these waste products, but they also help manage our fluid volume as we consume liquid. Our most common type we talk about is going to be hemodialysis. Hemodialysis generally is performed at a dialysis center. Theoretically, can be performed at home, but much, much less common to see performed at home. So generally, we go to an actual dialysis center for this. And how hemodialysis works is we poke two big holes in you, one to get some blood and one to put some blood back. And we take the blood out, we put it through a physical machine that does all the work of the kidneys. Artificial kidney machine, basically. Normalizes all those ions, removes the waste products, and helps balance out that fluid volume. In our chronic kidney disease patients that get hemodialysis, normally we do this 3 days a week. Usually they're on a schedule Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Those are our most common ones that we see. And usually they have to travel for that dialysis. They have to go to wherever their dialysis center is. Here, locally in our area, we have a dialysis center in Messina and we have a dialysis center in Ogdensburg. But our only dialysis hospital is the hospital in Ogdensburg. They can do dialysis. They are inpatient in the hospital. In Messina, there's a dialysis center, but it's not affiliated directly with the hospital. And then, as I just mentioned, in a patient that has an acute kidney injury, maybe you need to dialyze them once or twice to help clear some things out. Maybe they just have a really severe excess of potassium or something like that, or somebody that has something strange like rhabdomyolysis. They might get dialysis 1 or 2 times, and then they'll be fine afterward. This is, excuse me, an image of a hemodialysis machine. You can see it's big, it's cumbersome. That's why we don't see it in the home very often. And we need to directly access these veins. So it's a little hard to see here. But what's going on is there is blood coming out of this person's arm. It's coming up through these tubes, probably coming into all these wires are too tangled up. I believe it would go into this pump first. It's coming into this pump and it's being pumped over and into this filter thing. And inside this filter is a liquid called dialysate. And when our blood passes through that, it can help to exchange all those different ions and everything. This machine will also help remove that excess fluid volume. The dialysate will help remove the waste products. The blood will come back out the other side. It might go through, some of these are probably some other filtration steps, and then it'll come up through this pump and get pumped right back into your arm. This happens slowly over time because we don't draw all your blood out of you in one continuous stream and then feed it all back into you in one continuous stream. When the blood first comes in, it's going to have a really high concentration of all these things. But because it's getting injected back into a vein and going back to the heart, what we're going to see is throughout the time that you're in dialysis, we have this sort of exponential decay of the waste products that are in your blood, because every time it goes back to the heart, our concentrations balance out throughout the body. Peritoneal dialysis, super, super cool, much less common than hemodialysis, but it can be done at home. So I have another picture for this one. It might be worth going to this picture for a second to start with. These patients have a permanently placed peritoneal catheter, which is this access that comes and sits in their peritoneal cavity. Remember, we talked about the peritoneum as that anterior cavity of the abdomen. And what happens is you take your big bag of dialysate, which is essentially the same fluid that we use in hemodialysis, and you hang it high up in the air, and all that dialysate will flow down and fill up the abdomen, and all those waste products and everything can diffuse across the membranes within the peritoneum and have the same basic process as hemodialysis. Normally, our peritoneal dialysis patients have to do this every day. I feel like most often when I see this as being a thing, they start it at night and then they are done by the time they wake up in the morning. I think this used to be possible just literally using bags and gravity. All the videos I see now about peritoneal dialysis, they are still using a machine, but the machine isn't quite the same as hemodialysis where it does all these complex processes. It's basically just a pump that for the certain amount of time pulls all the dialysate from one bag and puts it into the abdomen. and then lets it sit for a little while, and then turns on a different pump that takes all the dialysate out of the abdomen and puts it into your little drainage bag, which is somewhere gravitationally lower. Peritoneal dialysis is really cool. Your patients are very well educated on their peritoneal dialysis, or a family member is if they're allowed to do this at home. So use them as a resource to help, get education when you're with that patient on how you can best care for them. All right, complications associated with both hemo and peritoneal dialysis. They all have some things in common because they're all still dialysis. They all involve removing fluid volume, which can lead to hypotension. They can lead to dysrhythmias and muscle cramps. Those are very electrolyte based things. Potassium, calcium, and sodium are really important for muscle function, which can lead to dysrhythmias because our heart is a muscle, but also to muscle cramps elsewhere in the body. When we have a patient who is on dialysis, really regardless of whether or not we're transporting them just for their dialysis today, or just because of something to do with their dialysis, we try and bring them to a dialysis center. Now, the biggest reason for that is if your patient is a Monday, Wednesday, Friday dialysis patient, and it's Tuesday at noon that they call you, well, when they get to the ER, if they end up being in severe enough condition that they need to get admitted, well, tomorrow morning they're going to need dialysis. And if they are not at a dialysis hospital, they will not be able to get dialysis. So we try to bring patients to dialysis hospitals when dialysis is something that they might need, as it's reasonable. I once had a patient who was in active seizure. I was a BLS provider. There's nothing I can do to force this seizure to stop, and it wasn't stopping. She was a dialysis patient, but I went to the local hospital that wasn't a dialysis center because it was what was safest for the patient to get that seizure under control and then transport them out to an appropriate dialysis capable hospital. All right, AV fistulas, something that we see in our hemodialysis patients, not really in our peritoneal dialysis patients. Fistulas are these little surgical connections that are made between an artery and a vein, and it helps plump up this vein so that they're very easy to access. I have a picture of an actual one on the next slide. This helps a lot with access. Two really big things that you can stick two giant needles into to quickly pull blood out and put blood back in. We can't take blood pressures on an arm that has a fistula because they're very fragile. It's usually pretty easy to notice a patient's fistula. So if they're unresponsive or something like that, it's pretty easy to say, oh, is it okay if I take your blood pressure on this arm? But I try and ask that question regardless. Actually, what I tend to say is there any reason that I couldn't take your blood pressure on this arm anytime that I'm putting a blood pressure cuff on somebody? Because there are other more subtle things that also block us from being able to do BPs, like a past mastectomy or vascular surgery on that arm, something like that. AV fistulas are our big one that we talk about, especially in this section of the course. All right, an AV fistula bleed. So this is a picture of a real AV fistula, and you can see some of the way that it looks outside the body. It's this big, lumpy, snake-appearing vein that is very quite large on the surface of the skin. This is a bleeding fistula, and they look super, super scary because they can put out a ton of blood very quickly. The thing about these is they're really easy to control if you control them correctly. So I'll go to this next slide here for the first technique for how to control a bleeding AV fistula. And this is just take a small piece of gauze, like a 4x4 that you folded into 4 pieces. So you have a nice thick 4x4, 2 fingers, and just apply pressure directly over the hole. These little lines right here, these are supposed to be the holes from the needle having gone into the AV fistula. Just that pressure, and you should be fine. Dr. Coates, our medical director, really likes to say that all it takes is just a finger on the hole. These are a low pressure system. A little bit of direct pressure can completely stop the bleeding. But what won't stop the bleeding is just wrapping more and more and more gauze around the spot. That will just slowly keep soaking through, soaking through, soaking through for a long time. And we don't want that. A piece of gauze, two fingers, pressure. Usually they're somewhere here on the forearm. So a little bit of pressure, and you're golden. The other thing, this recently was a big deal in the UK and in Australia, which is where this poster comes from. That's why it says call 999 instead of 911. And it's called the bottle cap method for AV fistula bleeding. So I've actually seen two things here. One of them is very similar to the gauze technique, and it's to take a bottle cap and put it upside down and put your fingers inside it and use that to hold pressure. That's supposed to be like a homebrew thing if you don't have gauze on you. What this particular paper that this came from advertised was some paramedics that took the hollow side of a bottle cap, this part of the bottle cap, flipped it over and put it on top of the bleeding fistula and allowed just the bottle cap to fill up with blood while keeping some pressure on it so more blood could develop. And you can see that it created this sort of jelly clot underneath that helped stop the bleeding. So another option, but this is meant to be, like homebrew for people that don't carry gauze around with them. If you're on the ambulance, get out a piece of gauze, use two fingers, and maintain that pressure till you get to the hospital. If you're not on the ambulance and you want to try out this crazy fancy thing, all I'm saying is don't go get the cap off your water bottle from the front to try this when you have sterile gauze pads. But something interesting to know about other context of these AV fistula is really just keeping in mind to treat for shock when it's necessary. Remember that managing massive hemorrhage comes before all the other ABCs, and this is really easy to control, but it also has a really high potential to cause massive bleeding if we don't control it. So get this controlled quickly, and then go through the rest of your ABCs, and treat as appropriate to get this patient to the hospital. Easy thing to manage, but super, super frightening when we first see it out the gate. Just remember to stay calm, and it's a really simple management. And that's all it is. 20 minutes on that last section on renal disorders, and we are all set. It is 11:30 p.m., so I'm just going to end this one here, and I will see you all in class on Monday.